I'm going to discuss our Trust's findings when we investigated surgical cancellations in patients from the most deprived populations, the factors we believe affect this, and our community-centred approach to address these issues. There is a well-established link between higher social deprivation and increased surgical risk, but what is less well understood is how inequity presents within perioperative pathways and how secondary care can have agency to make impactful change. We applied the Core 20+5 framework to our surgical waiting list of 90,000 patients and found 1 in 5 patients waiting for surgery lived in the neighbourhoods with the highest deprivation, according to their Index of Multiple Deprivation quintile. Patients from these higher-need communities, shown in the table on the left, experienced cancellation rates of up to 5% higher than our Trust average. And in the next table, we compared this cohort with London and UK benchmarks and found cancellation rates of 1.4 to 2.6% higher for clinical and patient-initiated reasons. This suggests that our most deprived patients are the least likely to progress successfully through the elective pathway. This matters because short-notice cancellations cause distress, financial hardship and poorer outcomes, while also wasting theatre capacity and reducing morale. Together, these factors undermine the delivery of the elective recovery targets. Next, we looked at drivers behind cancellations. This fishbone diagram highlights barriers to accessing surgery. We found that our greatest opportunities for change, in green and yellow, align with patient engagement, communication and their health conditions. 15% of cancellations were for clinical reasons, most commonly diabetes and hypertension. Patient-initiated reasons accounted for 36% of cancellations, almost half of which were due to patients either not attending or declining treatment. And notably, 5% of all cancellations were patients declining surgery on the day itself. So we know that we have the chance to make impact on the very areas for which we are an outlier. The challenge is how to deliver that change, an issue that the NHS is currently trying to address across multiple sectors. Our response is a community pre-op optimisation day co-designed with patients. We have engaged stakeholders across our trust, local primary care, public health and neighbourhood organisations, and importantly lay representatives and focus groups to shape the service around real barriers. The model draws on evidence from other successful community initiatives, including the Musculoskeletal Community Appointment Days and the PrepWell Prehabilitation Programme. We are running 3 pilot days, each embedded within a PDSA cycle, assessed by a set of co-designed outcome measures. The aim is to translate this into a long-term service. By moving perioperative services into the community, our approach supports the NHS 10-year health plan, and it is in the community where secondary care will find its agency to influence outcomes as the NHS priorities move beyond the hospital setting.